Hello, everyone. Thank you for joining us. It's noon. We're going to go ahead and get started. I'm Jody Strother, and I am the coordinator for the ECHO through PPCL. Today is our seventh perinatal mental health tele-ECHO session, and our focus will be on infertility. And we wanted to take a few moments just to go over our agenda. We're going to stick to this as much as we can. But today, I did want to request, we do not have anyone that submitted a case presentation. And the ECHO model includes a didactic presentation followed by a case presentation, and they do not have to match topics. The idea is that you have a hub team with experts in their field, as well as the experiences and expertise of the participants, that someone could bring a case presentation to this session and have the opportunity to ask questions, get feedback, get recommendations from your peers. And I want to take just a second to offer the opportunity for anyone that's on this call today to volunteer, or if you have a case in mind that you would like to present very informally. We don't get any protected health information, so we don't need to know name. We don't need to know the real specifics. It's just very general um, to discuss after Katie presents on our topic today. So I'm just going to be quiet for a few moments and give uh, anyone that would like to volunteer a chance to speak up and um, let us know if you have a case that you'd like to talk amongst our group today about.
So if folks want to think about it during our presentation, I mean, we'd love, again, as Jody's saying, it does not have to be formal, but really with the tele-echo model, it's a learning community, and so your cases really are the curriculum. So we want to make sure this doesn't turn into just a didactic presentation, because the idea, and that's how we're able to continue to offer the tele-echo. Doesn't need to be complicated, doesn't need to be interesting. And you don't need to have the right answer. That's kind of the idea. So maybe folks can think about it. And then certainly if we still don't have a case for today, please consider doing it for our next tele-echo. And it really helps the group and helps the whole learning community.
We'll move forward with introductions. You can also put it in the chat if you'd like to consider it during the didactic presentation. You can mention it in the chat and we'll come back to you. I'm Jody. I'm a social worker by trade, and I am the coordinator for the ECHO. I'm also the program manager for the provider to provider consultation line. The work that we do with the provider to provider consultation line is we provide consultation through telephone or email for providers like yourself across the state regarding pediatric or perinatal mental health support. You can call us and discuss specific cases with us one on one. If you're a prescriber and you have a question about medication or diagnosis, we can link you to one of our psychiatrists like Dr. Finelli. And we can also help you find resources in your area that are specific to the needs of the patient or client you're calling us about. So we call, vet those resources, make sure that they're appropriate, and then we get that information back to you so that you can then provide it to your client, discuss about the next level of care or next steps in their care. We also do trainings, and the ECHO series are examples of those trainings. So you can scan that QR code if you're not familiar with us, or you can just peruse our website to get more information, or you can always just give us a call and we can walk you through if we can help you with any situation that you may have. But I want to let Dr. Finelli introduce the rest of our hub team, and then we'll get started with our presentation.
Thanks, Jody. Hi, everyone. Juliana Finelli. I'm a general psychiatrist and child psychiatrist. My clinical focus is perinatal psychiatry and infant and early childhood mental health. And I work with PPCL as a psychiatry consultant along with my colleague, Dr. Vincent, and I serve as the facilitator for this teleecho. So I'm going to let Katie Abear introduce herself.
Hi, everyone. I'm Katie Abear, and I am a LCSW, a licensed clinical social worker, and I work in private practice at Bloom Mental Wellness in Lafayette, Louisiana.
Thank you, Katie. And Katie will also be delivering our didactic portion today. Oh, Lena's on. Lena, would you like to introduce yourself?
Thanks, Dr. Finelli. Sorry, I was a little late. We had a consult call come through, but I'm Lena. I'm one of the mental health specialists for PPCL and also perinatal mental health certified, and I serve as kind of IT support for these echoes.
Thank you, Lena. And then Dr. Paulazina isn't on yet. She'll be joining us a little bit later. She's also a member of the Hub team representing psychology and also nursing. So without further ado, I'm going to turn it over to Katie Abear for our presentation.
Okay, thank you all for having me. We'll be talking about infertility today, specifically understanding the individual, the couple, and then the role as a mental health professional. Next slide. So, very briefly about me, I attended the LSU School of Social Work, and I'm a 2012 graduate. I'm a board appointed clinical supervisor. So, I supervise master level social workers. I spent about 8 years in the psychiatric realm before 2020 kind of changed the world for a lot of us and um, broke away and partnered to open a mental health practice in Lafayette called Bloom Mental Wellness. That same year, I became perinatal certified and then began volunteering for Postpartum Support International. I am a support coordinator for the Acadiana region and love that work. Also co-lead Climb Acadiana, which is PSI's kind of fundraiser for perinatal mental health. I am an infertility survivor and an IVF mama, and I am glad to be talking today. Next slide. So, a quick disclaimer, we'll be talking about infertility, the accompanied loss, and the emotional challenges that are interwoven in a fertility journey. We recognize that these topics are deeply personal for our attendees, so your well being is important. Feel free to take a break, step out of the room, turn off your camera. My goal for the presentation is to provide information, understanding, and awareness, honoring so many different paths to building a family. Next slide. Okay, let's look at, sorry, I don't know what's going on. But let's look at objectives. So for today, we're going to recognize infertility as a biopsychosocial crisis. We're going to understand the emotional and relational impacts. We're going to review recent mental health research. And then we're going to look at evidence-based therapeutic interventions. Next slide. Okay, let's start by defining what is infertility. So according to the American Society of Reproductive Medicine, infertility is defined as a disease, condition, or status characterized by one or more of the following. So the inability to achieve a successful pregnancy based off of something we know about the patient, their medical, sexual, reproductive history, age, physical findings, but something that is identified, preventing them from achieving successful pregnancy. The need for medical intervention to achieve successful pregnancy, and or any individual having regular unprotected intercourse without any known impairment to their reproductive ability. This would trigger an infertility evaluation if someone has been trying for 12 months, if the partner is younger than 35, and if the partner is older than 35 for 6 months of trying. Next slide. Okay. Infertility by the numbers. So a few statistics. Infertility impacts approximately 1 in 6 people. The male factor contributes to approximately 30 to 40%. So really highlighting here that it's just not solely a women's health issue, and we need to be able to account for and consider the male factor. Approximately 1/3 of infertility cases are primarily female related, 1/3 male related, and then we have kind of 1/3 involving either both partners or something more so that we will call kind of unexplained infertility. Only 1 in 4 infertility care needs in the US are currently being met. And then secondary infertility impacts 11% of couples in the US. And so that would be if someone was able to achieve a successful pregnancy and now they're struggling in a subsequent pregnancy. So to highlight what we're really emphasizing today, which is that infertility affects emotional, relational, financial, and physical health, not just our reproductive health. Next slide. Okay, we won't go through all these. But I just added this slide because I wanted people to know that when you're working with a patient or a client, you're going to hear that there might be certain factors that they're bringing up. These factors may increase their infertility risk. So either they know that's why they're struggling or they might be concerned. You know, some of the things I will personally hear the most about is PCOS. If someone has or believes that they have maybe endometriosis, maybe the male sperm factor, definitely smoking, vaping, sometimes marijuana use, so THC for especially that male factor as well. But just to know that there are several factors that you might be hearing. Okay, next slide. Okay. So here we'll spend a little bit more time because this is where I think it's the good stuff of what we want to take away from today. The emotional landscape, I think I really like this terminology because it's so fitting for infertility. It's truly an emotional landscape, such a landscape of emotions from hope, which is so essential, to anxiety, to sadness, to uncertainty, to jealousy, to grief, all intertwined in this one journey. And I think really understanding the individual before they've even come to a diagnosis of infertility is really backing up. We kind of are a society, maybe as little girls, we were gifted a baby doll and we played mom or we played family. Throughout maybe our young adulthood, we had sex education. And we were really taught that, we had to be careful with this idea that sex would lead to becoming pregnant. And it wasn't really about if, but it was more about when we would become a parent. Maybe marriage, we're having conversations as a couple in our relationship, and we're talking about how many kids do you want? Well, how many kids do I want? And so when this diagnosis comes, it definitely can be described as like whiplash. Very shocking, very confusing of what's happening. And so there's such an array of emotions that are coming. As we talk today, we're going to kind of look at 3 different categories. You might be dealing with someone in front of you that's never been able to achieve pregnancy. The next kind of category might be people who cannot sustain a pregnancy. So they're getting pregnant, they're seeing that positive pregnancy test, but they're not able to sustain that pregnancy full term. And so there's a lot of loss or miscarriage maybe in their story. And then there might be this other category where there is some medical diagnosis where they know they're unable to have a child. The one that comes to my head would definitely be maybe a hysterectomy, an unexpected hysterectomy that they were able, so they know they cannot carry a child themselves. And so when we think about these 3 groups of people, we want to look at some of the themes. First one, ambiguous loss. So ambiguous loss is this grief that lacks closure, lacks finality. And what's hard about that is that a lot of times infertility does lack closure. We don't know if we're grieving that we're not going to get pregnant for another 6 months, or are we grieving the fact that we may never get pregnant at all? disenfranchised grief. So this grief or loss that people feel like they can't openly acknowledge, they feel like they can't talk about. Maybe my client is telling me, I didn't lose a baby. I don't feel like I have the right to say I'm grieving in the same way. It's not like I lost something where they feel like there's nothing tangible. It's the lack of not being able to have that thing. So this disenfranchised grief, identity disruption, what I talked about before. So who am I if I'm not going to be a parent? Because this is what I just assumed. This is what I thought, or this is what I really desire to be. Chronic uncertainty. We don't know. And that can truly make people get so in their head of what route to take or what they should do or what the plan should be, which is definitely a theme. So, this chronic uncertainty of what their future will look like. Shame, the layers of shame that they feel, and self blame for themselves, or also considering the partner, right? The blame that maybe the partner is carrying. So, mental health outcomes that we are going to notice, we're going to see anxiety, we're going to see depression, we're going to see trauma symptoms. Um, you know, one that comes to mind is an experience where a client had such a long infertility journey, made it all the way, now was in an adoption process, and then birth mom decided to keep the baby. So these layers that kind of come with this journey, relationship distress, looking and evaluating the relationship as a whole. What does their marriage look like? How is the couple navigating this together? Social isolation, withdrawing. Their social situations are changing, and they're not maybe able to relate the same as they were. Um, they're feeling certain ways about the baby shower or the friend getting pregnant, and so these social experiences are becoming more complex. Next slide. Okay. So this was just a really brief cycle that I wanted to show of what month by month can look like. So every single month, if you're working with an individual or a couple, they might be experiencing this cycle over and over again. So hopefully they're able to start the month off with some hope because it's a fresh month and a fresh opportunity for potentially this being the moment that they are able to get a positive pregnancy test. It leads into this waiting, this uncertainty, followed by this loss. Another failed month is oftentimes how it's stated. Another month of trying and it not working out. Another month of it not being what we hoped it would be. Then the recovery. I often tell my clients, we have to give ourselves 48 hours. 48 hours to feel, to be sad, to grieve, before we try to come up with this new plan. Not all clients will do this, but I will say that there is in the infertility realm, this desire, it's almost their coping mechanism or strategy that if they have a new plan or something new they're trying, it's what helps give them hope for the next month. And so before they are so eager to jump into figuring out what happened, to planning for what different they can do, just to sit in that grief, to feel it so that they are able to sustain this process. And then it leading hopefully back to hope as they try again for the next month to come. Okay, next slide. Do we have time? How are we doing?
We're good,
Okay.
Katie. We have like another
Okay.
5 minutes or so. You're good.
Okay, I'll only maybe say this is just a few quotes that I pulled, and I figured I could just go past them if I needed to. But some things that you'll hear people say, just kind of hearing from different perspectives of how they might be navigating this journey. I feel like so much is being robbed for me. That lack of control. Sex feels like a job. The relational impacts. My body is failing me. There are so many unknowns, and I have this urge to figure it out. People have it worse than me. I'm not dying. I need to stop complaining. The minimizer. I can't be around my friends. I'm so angry with how easily they get pregnant. I can't listen to one more conversation about what's the best sippy cup. That social impact and realm of how these social situations, we suddenly are with our support network, but we feel so alone and we feel so isolated, and we don't even know how it makes sense because we're not always technically by ourselves, but we're feeling so lonely in our journey. Next slide. So really giving some attention to the couple experience, because truthfully, just as many people come and seek support individually, they're also seeking it as a couple, which is a beautiful thing. We're looking at different coping styles. We're looking at communication strain, medicalized intimacy, financial burden, huge part of this realm. And then decision fatigue, which I find the financial burden and the decision fatigue can sometimes go hand in hand. What if we have one partner who doesn't really want a certain path and another partner does? And what does that look like in this realm of both of them navigating their own individual infertility journeys? Next slide. Okay. So now that we kind of maybe gave a snapshot of what the person may be experiencing, what is our role now as the mental health professional? We really, really, really want to look from an integrated behavioral health perspective, because we know that improves outcomes. We need just as much the medical side, the reproductive side, as much as the emotional and social and relational side. We need to work together. CBT, ACT, EFT, emotionally focused therapy, mindfulness. This is going to help reduce distress. And so a lot of our role is evaluating what is their distress and how can we help reduce the distress that they're feeling as they're navigating their journey. Self-compassion predicts resilience. I think this is essential in this realm to have self-compassion work. Again, I will not go through all of them. I know I'm not supposed to be so wordy on a PowerPoint, but kind of wanted you to have it in case you want to reference it later for your own people. But just two of them. My worth is not measured by my ability to become pregnant. Hope and heartbreak can exist together. I deserve the same compassion I so freely give to others. Okay, next slide. So a little redundant, but just to kind of wrap it together, we have assessment, right? We're looking at the person as a whole. Where have they been? What has their journey been? What was their relationship to becoming a mother or a father before they even heard the news of this struggle? Are you meeting them in the place where they have a diagnosis, or are they just concerned about struggling? So kind of where are they and what has happened? We can pull in, of course, cognitive behavioral therapy. We love acceptance and commitment therapy, emotionally focused therapy. A lot of times we're identifying the fact that they're feeling two different things. They're feeling true joy for their friend because they love their friend and their friend got pregnant and they're excited. But the reality is they are so incredibly jealous and frustrated that they don't have the same thing. And that doesn't make them a bad person. That makes them human. And so being able to, from that emotionally focused therapy lens, humanize it. Grief-informed care. There is so much grief that is happening throughout this whole process. And even, I won't get on this tangent, but even from the opposite end of things, we'll see this theme of like a kind of tie in as like survivor's guilt. When someone has been in the support group, they have met so many great relationships, and then they get pregnant. And the guilt that sometimes they feel, although they've longed for this for so long, it kind of can play into like this survivor's guilt category. But grief-informed care, mindfulness, and then couples counseling. If you are working with someone with infertility, I highly recommend that you are at least kind of just talking about what couples counseling could do and how it could be beneficial to them as a whole. Okay, next slide. All right. So, what do our clients need? They need validation from us. Um, what can validation look like? It makes sense that this is so painful for you. That makes complete sense to me. Compassion. This might look like you don't have to be okay with me. In here, right now, you don't need to feel like you need to be okay. Realistic hope. So essential. Um, we want to be realistic. We have no idea if they will ever get pregnant. And so we don't want to instill some hope that they will, because we don't know that. And so today we can always say, it seems like no one's telling you you won't get pregnant, but you're struggling. And that's where you are today. And we meet them there. Community. What does their community look like? Is it changing for them? How can they communicate to their support networks so their support system knows how to show up for them? I'll often say that, those who struggle with infertility, there can kind of be this yo-yo of what they need at any given time. And so sometimes it might be that they have to speak up and say, okay, I want to talk about it today. Where maybe a few weeks back, depending on where they were in their cycle or in the month, they really could not talk about it. And maybe they responded in a way that made people think, okay, I won't ask questions. And so we're kind of ever changing, and we need to be able to communicate that sometimes when we're building community around us. And then permission to grieve, allowing them permission to grieve, to feel, and to know that this is what makes them human. And this is hard, and there's no rule book. Next slide. Okay. I could do a presentation on each of these things at the bottom, but I definitely did not have time to get into any of it. But what I do want to say is that it's really important to note that not all clients can or will want alternative interventions due to physical, financial, spiritual, emotional reasons. So it is not our job to suggest to them their options. I assure you, they know that there are things out there. And if they are bringing it up, I think it's different than educating them if they are asking you, like, I don't know what's available to me or to my husband, that's different. But just being very careful with not pushing or suggesting or that kind of theme of fixing. But when you're working with this population, of course, not only are you working with the infertility realm of their emotional situation, but you might also be carrying them and supporting them through fertility treatment. So IUI, IVF, surrogacy. I have a couple of cases where we're using surrogates, and that's a whole different realm. Adoption process, and what is that for them? Medical procedures, and understanding the language that they might be using. So laparoscopic surgeries, varicoceles, some of these things that they may be navigating. And then, of course, pregnancy loss. And I really should have put in here too, the loss of embryos. Sometimes, we don't always highlight that, but definitely understanding from that fertility realm what that might be like for them. Okay, next slide. So to kind of wrap it all together, the key takeaways. Infertility is both a reproductive and a mental health concern. This season brings about a unique combination of hope, grief, uncertainty, isolation, and stress. Compassionate, evidence-based care truly changes outcomes. Next slide. So I could have put a bunch, but I feel like these are the ones that are my go-tos when it comes to resources for infertility. And I'd love to hear any others that you guys may use or really like with your own patients or clients. The American Society for Reproductive Medicine is excellent. Resolve, I'm sure a lot of you guys know about that, the National Infertility Association, Postpartum Support International. We're so blessed to have them and their hub of support groups that we're able to reference and use. Sarah's Laughter. They offer faith-based Christian support to couples and to individuals. And I have a lot of people who will use Sarah's Laughter, and I don't find they're all very spiritual clients. And so it is faith-based, but I don't think it's um, really pushed in these support groups. And so it's maybe worth a try, even if it's someone um, who may not be looking for that realm. And then I did want to give a shout out for in Baton Rouge, we have Elizabeth Vivian LPC, who does have a in-person infertility support group called Hope and Waiting, if you are in the Baton Rouge area. Next slide. It's probably references. Thank you.
Thank you so much, Katie. That was such a great presentation, as always. We have a little bit of time for questions. If anyone wants to put a question in the chat or just come off mute and ask.
I guess I'll jump in. Hey, Katie, thank you for the presentation. I knew you spoke a little bit about couples. I guess I was wondering, like, I don't know. I guess like if you had any additional thoughts on couples or like, uh, like interventions with because I guess I assume that in the majority of cases, right, like in a like assuming like heterosexual relationship, like it's a woman who is coming in with distress over it. But I guess like to what degree is the level of distress like typically like pursued or acknowledged like in the in the partner. Unfortunately, I'm sure in a lot of like systems, society, like family social structures, like the onus of it is put on the woman. And to what degree does she kind of, this is like I'm sorry, this is like a lot, but I guess I was just wondering if you had any more thoughts on like kind of couples based interventions or, assessments.
Yes, I find when I am working with the male, so things that I'll see in that situation are honestly the non-caring parent for a same-sex relationship. What I find that the non-caring parent can hold this weight of like, I am not the one having to put my body through all of these things. And so they can almost feel like their feelings aren't as valid. Or they might be asking questions like, I don't really know, like, I don't want to put anything else on her because she's already going through so much. And I'm always really proud. I have two current guys right now, and their wives, I don't believe are in, to my knowledge, are not in therapy, but they are. And I think that's great because a lot of that language is just them sharing. Think they just don't know where to go to talk about this and they don't want to put it on her. And so I see a lot of that, them feeling like it's not their body. And so what and how much can they voice? And then maybe the other thing I would point out is the non-caring parent or person, male or female, tend to take on a lot of the financial burden. And so I see a lot of that stress, a lot of anxiety of like, I don't know what will happen. So do I need to save up money? What will this look like? And so some of those financial conversations that is just so challenging on the relationship as a whole. And I guess I didn't put this in there, but it is not uncommon for me to have a comment from a couple, um, male or female, where they say, during our fertility journey, we've never been closer. So sometimes it's not always that they are having strain in their relationship, although that is definitely something that we see for sure because it's just high stress. But some clients that I've worked with from an infertility journey all the way through like a pregnancy and postpartum, in looking backwards, their reflection is postpartum, we became very strained. But fertility, we were so connected. It's almost like that journey brought us together. And so it's truly, it could go either direction from when we kind of look at the couple experience. I hope I answered your question.
Yeah, you did. And that's great. That's great that those guys have a space because that's, right, that's another part of it too, is like
Mhm.
not feeling empowered to seek out that support and help. Yeah, thank you.
Yeah.
Thank you. And thank you again, Katie, for that great presentation. And thank you all in our audience. We actually have a couple of folks who were volunteering to talk about cases, which is fantastic. So I believe, Lena, Ali Rodriguez wanted to talk about a case. And then I think if we have time, uh, Jen Latimer would as well, just to give everyone a sense of kind of how we do the presentations. The first is that we don't include any protected health information. So any information that might identify a patient, we would ask you not to share, including, where they live and, kind of more specifics, things like